Our next presenter holds a Bachelor of Medicine, a Bachelor of Surgery, Doctor of Medicine, Internal Medicine, specialty certificate in education such as gastroenterology from the Royal College of Physicians. His clinical experience includes casualty rotation, intern pediatric rotations, internal medicine, elect and call on daily wards round and teaching medical students at the University of the West Indies. He's had a few publications, including some on irritable bowel syndrome, the electrocardiographic referral pattern, and acetaminophen toxicity. He's a graduate of Child Month, okay? Mona Prep, Campion College. He's married, 2 kids, of the pair. Please help me to welcome Dr. Mike Mills.
Good morning, thank you very much. Well, you never know what you're going to get out of your CV when you submit it, you know. Okay, right. Now, all of these terms, I'm sure someone in here has said this to themselves or in a group of people before. I have a gut feeling about something. Butterflies in the stomach. Can't eat when I'm expecting some results, but it's a test result to come back and you can't eat. Have a lump in the throat. Have a gut-wrenching decision to make. I get diarrhea before a big, not me, you know, I'm talking just generally. Get diarrhea before a big speech. And I feel nervous, whatever that means, okay? And all of these things suggest something, which you can kind of surmise a little bit. Now I'm going to ask certain people to do something for me. Cheryl Blissett, when you hear your name, please stand. Ketania Morris, where are these people? Don't be afraid to stand. Tyrone Davis, please stand. There you go. Thank you very much. C.Q. Allen. Meganton Brown. Please stand. Righto. So what do you think is happening with these people? Stress. Because they don't know what's going to happen, right? Well, not all of them are stressed. I'm sure CQ's not stressed because she knows me very well, so she knows I'm not going to do anything dangerous, right? The body language, you see the hands on, yeah. Thank you very much. You can all sit. Stress, right? They're all under stress, okay? And this is something that everybody experiences, but the way you react to stress depends on what you expect. So your expectations have a lot to do with the stress response. So Mark went through some of the basics of stress, but I can't leave out any of my slides, so I need to go through two. So stress was first coined by the Hungarian endocrinologist Hans Sele, and he postulated that it was a challenge to the homeostasis of an organism. So that's what stress is, anything that challenges the internal normal mechanisms. Okay? Stress is also the body's response to a stressor. Okay? And the stressor is that thing that causes stress. So kind of like a roundabout definition. There are 2 types of stress as Mark described, eustress and distress. Okay, so examples of eustress would be like having a baby. So pregnancy would be like eustress. And examples of distress would be like having a baby. So the same thing could be eustress and distress depending on, the circumstances. So that tells you that the stressor itself can mean different things depending on the situation, okay? So they're not fixed. You can also have interoceptive stress and exteroceptive stress. So interoceptive stress is stress that's on the internal, so something is going on internally. So it's something to do with inflammation in the body or change in the hormones, all the things that happen in the normal state, which sometimes when there's a disease process inside, the body responds to that, and that's interoceptive. Exteroceptive stress is what we're more used to. The psychological things around us, the things in the environment outside which impact us. Okay? Now, this curve basically shows how people function when they're in a stressful environment. Now, everybody has some stress. If you don't have any stress, you're dead, okay? So everybody has some amount of stress. But there is optimum stress as well. So depending on where you are on the curve, you will be functioning at a certain level. So on one axis, we have arousal, and on the other axis, we have performance, okay? So if you're having a low level of arousal, and we're talking about work now, we're not talking about anything else. Low level of arousal, not that kind of work either, then your performance will be low. Okay, so you're not interested in the task and you're not really doing anything. But as your arousal level increases, your performance also increases. And this is what Mark was alluding to when he was talking about the job situation, where if you get a promotion or something, then you will automatically perform better. So that's good stress. And there's a certain level, which varies depending on the individual, where you can have your optimum amount of stress when you're at the top of the curve. Okay? But if the stress continues, then you develop anxiety for whatever reason, and your performance will fall. So the curve then tends to go down. Okay, so impaired performance because of strong anxiety will reduce your effectiveness. So it doesn't continue indefinitely. And this is something which you need to bear in mind. So, normal situation, when you have adaptive physiological stress, the individual will be maintaining a certain straight line or homeostasis. And as you go through life, you get different stressful events, and the body will adapt to that and return to baseline. And that's physiological. That's something that's expected. Okay? Now, you also have a scenario where you will have maladaptive stress. So if the stress is prolonged, then depending on the duration that it's prolonged, after a while, your body mechanisms will start to break down, immune system and so on, and you will have a decline in your overall normal functioning or homeostasis. And there's a red line here, which basically shows the artificial cutoff, where if you fall below that in terms of your performance and your body mechanisms, then you will start to introduce either pre-existing diseases will start to get exacerbated, like diabetes, hypertension, or you may have new diseases being acquired, like immune conditions and cancer and so on. So that line varies from individual to individual. Not everyone follows the same path, okay? And if you have a very short amount of reserve, then even if you don't have a lot of exposure to stress, you can fall below this artificial maladaptive line. And some of those factors which will determine who falls below the line faster would be something like genetics, which is hard to study, your early life experiences. So if you had been abused as a child, or if you had some kind of major life illness or threatening environment, that may impact your ability to cope. Other cognitive factors, so increased education also impacts on how you respond to stress, and then environmental support as well. So not everyone will face stress in the same way. So how does this impact on disease? Well, we know that there are lots of diseases which are associated with stress. We spoke about hypertension, myocardial infarction. We're going to speak about some of the GI-related things. Cancer can be associated with stress. Things like systemic lupus, obesity, loss of periods or menstrual problems, skin disorders, sexual disorders, chronic fatigue. All of these are associated, not necessarily caused, by stress. In terms of the GI tract and stress, the important thing to focus on is something called the gut-brain axis. So your nervous system, from the GI standpoint, has three components. The first one is up in the brain, and that's predominantly to do with the hypothalamus and amygdala, where you're focusing on the emotional system. So the emotional nervous system would be up in the brain. And it's connected to the intestine through the vagus nerve and the parasympathetic and sympathetic nervous system. And it synapses on a lot of neurons inside the intestine. About a fifth of the total connections in the brain are reproduced in the intestine, and that's known as the enteric nervous system. And that controls the opening and closing of all the valves and secretion of all the fluids from the different parts of the intestine, the absorption of all the nutrients, the release of any toxins, the protection from all the bacteria and funguses and all the things that will enter into the intestine. If you think about it, your intestinal environment is constantly changing and being exposed constantly, and the enteric nervous system is responsible for preventing you from having an out of sync enteric or gastrointestinal system. The final component is your gut enterobiome, which is basically all of the bacteria and funguses and other microorganisms which live inside of you, which have their own nervous system, which interact with your own by releasing various molecules which your intestine will pick up on and will affect the way that you function normally. And this is where the whole business with probiotics and so on comes in. So this is what we're going to focus on to try and explain how stress can impact on the gastrointestinal tract. So just briefly, to go back over, the brain would be the kind of overall control mechanism with the emotional nervous system, where you have your visceral stimuli coming in from a stressful event, and that feedbacks on the intestine, usually through the hypothalamic pituitary adrenal axis, which is responsible for releasing cortisol eventually, which is one of your stress hormones. It also impacts on the intestine through this autonomic nervous system. And then all of those will synapse and cause changes in your mucosal integrity. So whether the intestine has enough mucus, or whether it has enough antibodies, or whether it has enough cells to cause you to release enough acid or to prevent infection. It also impacts on whether you are contracting your intestine very sharply or not at all. It controls whether you feel pain or whether you feel a sensation of stretch. And all of that feedback happens on a continuous basis. So the hypothalamus will release your corticotropin-releasing hormone, and this is what's responsible for a lot of the symptoms associated with psychological stress. Usually animal models, but they have studied the injection of this hormone in rats, for example, and then measure the stress response, and they can tell definitively that if you have a high level of corticotropin-releasing hormone, it will ultimately produce a lot of excess cortisol and produce the same kind of response as models where the animal is exposed to a psychological stressor like being shocked or something. Similarly, if you inhibit the amount of hormone that's being produced, then you can also show that you can inhibit the response in these same mice. So they know that by changing the levels artificially, you can produce a stress response, and so you can show that there's a direct correlation between that hormone pathway and a GI stress response. The autonomic nervous system, which is composed of two major arcs, the sympathetic nervous system and the parasympathetic nervous system, those are responsible for the usual fight and flight response that everyone knows about, where if you are in a stressful situation, you have increased heart rate and sweating, dilatation of pupils, and the whole increased motor tone, getting ready to either face the adversity or escape from it. But it's not as simple as just a global activation. It's a little more nuanced than that. We know that there are neurons in the intestine which have different functions depending on what aspect of the sympathetic nervous system is stimulated. So this may impact on whether individuals produce mucus in response to a stressful event in the intestine, whether it affects the amount of water that's being absorbed, whether there's a change in the mucosal permeability, allowing microorganisms to enter into the bloodstream and produce a negative effect, whether you have a change in the mast cell degranulation inside the intestine, which is responsible for producing histamine, which is responsible for a lot of your flushing effects and so on, or whether you have a change in the release of the peptides from the enterochromaffin cells, which are responsible for a lot of the little signals which go to the intestine and tell it how to function normally. So by changing the sympathetic tone, you can influence how the intestine works normally. And this is done through the vagus nerve, which is the predominant nerve which comes down from the brainstem and interfaces with the intestine. You can also change the immune function of the intestine by affecting your autonomic nervous system. Okay, so if you affect noradrenaline, for example, which is released from the end of the nerves and synapses, you can affect how much interleukin-6 is being produced, and that interferes with the amount of tumor necrosis factor alpha, which is a molecule which is responsible for modulating the immune and inflammatory response. And this is important in patients who have something like inflammatory bowel disease, which is predominantly mediated through the interaction of interleukin-6 and tumor necrosis factor alpha. And so by changing this, you can affect the way that individuals will present. More definitive studies looking at rats, for example, have shown that if you were to clip the autonomic nervous system completely, then you could completely cancel the GI tract immune or inflammatory response which is being caused by stress. And so we know that there's a direct correlation between these nerves and the stressful event. The hypothalamic pituitary adrenal axis, because it is in the more developed part of the brain, is activated by both the internal changes, so the inflammatory and infectious components that we described, as well as the external components like the psychological stressors. And because ultimately the pituitary will release hormones which will cause release of cortisol from the adrenal gland, we know that the peripheral cortisol response, as you know, cortisol is like is the body's own prednisone. It's going to be an anti-inflammatory. So you can modify the immune response in the body when you modify the release of the hormone from centrally. So just to sum up, we're talking about the brain-gut axis or gut-brain axis, depending on which one you think is more important, and the interplay between the brain's nervous system, the intestine's nervous system, and how stress can interfere with the immune function through that mechanism. It interferes with the barrier function of the intestine, and it also interferes with the motor function of the intestine. Now, it doesn't matter which part of the intestine. It could be the esophagus, it could be the stomach, it could be the small intestine, or the colon, or the rectum. So each of them have their own neurons, and depending on which part is affected, the symptoms will be different. So it's not one set of symptoms which will cover everyone. So there are not many conditions which are definitely associated with stress in terms of the GI tract. The functional gastrointestinal disorders are definitely associated. So the predominant ones that we'd like to focus on are irritable bowel syndrome and functional dyspepsia. Okay? So irritable bowel syndrome is a condition which is pretty common. We don't have any local data, but we do know that a significant number of patients do present with the symptoms suggesting irritable bowel syndrome. And these symptoms are chronic abdominal pain, and the pain is usually related to some kind of bowel movement. So there are two types of irritable bowel syndrome. There's a diarrhea predominant, and there's a constipation predominant. So the patients will have pain, and it's associated usually with diarrhea, and usually passing the stool will relieve the pain. Then there's another component of patients who have abdominal pain, but they have constipation, and passing the stool will relieve the pain. There's also a component of patients, a smaller subgroup, who have both. So sometimes they have diarrhea, sometimes they have constipation. And it's really, there's nothing which will predict which one will happen. The prevalence of the disorder is really approximately 10% in larger populations where it's been studied. More common in females, 2-to-1 predominance, but it does occur in males. It is important to exclude any alarm symptoms. So abdominal pain, diarrhea, and constipation doesn't mean irritable bowel syndrome. It could be something serious like cancer, for example. So if the person is having weight loss or bleeding, if they're over age 45 when it first happens, or if they have any lab abnormalities like anemia, for example, then it's not appropriate to diagnose irritable bowel syndrome. You need to exclude something else, which means doing a CT scan or an ultrasound, or if necessary, a colonoscopy, for example, to exclude something structural. The management of irritable bowel syndrome, well, it's predominantly education. So there's little pharmacy that's available to treat irritable bowel definitively. We know it's definitely associated with stress, but if you can change the way that the patient consumes certain foods, then you can impact their symptoms. So it's predominantly symptom-driven. If they're having constipation, then you manage the constipation by giving them fiber or one of the PEG solutions or any other laxatives. If it's diarrhea predominant, you can give them loperamide or cholestyramine, which is a bile acid sequestrant. If it's predominantly pain that they're having, then you can use antispasmodics or antidepressants. As we know, the central axis, as we described before, allows you to modify something central in the brain and have an impact on the gut. Or we can use antibiotics or probiotics to also reduce the amount of bloating that's associated sometimes. Reflux is another condition which is associated with stress. We do know that reflux is very common. About 60% of individuals will have symptoms once per year of a reflux episode, but fewer than that will have impact on their lifestyle. So when there's an impact of the reflux symptom, which is burning in the chest, associated with water brash, then that is what is known as reflux disease. Okay, and it's usually because of regurgitation of stomach contents, which are acidic or non-acidic, into the esophagus, where it's not designed to be. The symptoms are enough to make the diagnosis. So if they have the typical heartburn, then we know that it's associated with having excessive meals or fatty meals, lying down soon after eating. We know certain foods or coffee, alcohol may trigger the effects. We know that if you overeat as well. If it continues, then you may have evidence of erosions of the esophagus. So the esophageal lining at endoscopy will show these lines, which ultimately, depending on the severity, may end up with scarring to the point where the patient can't swallow because the esophagus becomes very narrow. Or you may develop rarely cancer of the esophagus with long-standing reflux, but this is very unusual because most patients would have been on some kind of treatment. The reflux is not confined just to the esophagus, so there are symptoms outside the intestine as well. So you can present with laryngitis or sinusitis, hoarseness, otitis media. It may exacerbate asthma or other respiratory conditions because the acid enters the lung when they bring it back up. Or you may have severe cases where patients present to the dentist with dental erosions because of severe reflux. It's important to ask about the reflux symptoms, though, if you want to make the correlation between the two. Looking at the pathophysiology of reflux, it's easy to see why stress would affect that. So because we know stress can affect the neurons, there's a condition known as transient lower esophageal sphincter relaxation, where the esophagus, which normally prevents food from going back up from the stomach because the lower part of the esophagus will close, sometimes you may have a situation where the nerve that controls that sphincter causes it to open at the wrong time. So not when there's any food coming into the stomach, but when the food is already in the stomach, the sphincter opens because it's under control of the autonomic nervous system, and so you're going to get reflux happening. And so stress can affect that. You can also see that other neuromuscular disorders may affect the emptying of the stomach. So as we said before, because the sympathetic nervous system affects the way that the stomach empties, if you have a condition where, for example, when you become stressed, your pylorus remains closed, then you won't empty, and so that's going to predispose food from leaving the stomach and going back up into the esophagus. Treating reflux is not done by treating stress, however. You still need to address the acidity aspect of it. So usually antacids or mucosal protectants or H2 blockers or the proton pump inhibitors would be the mainstay of therapy. But you do need to ask patients if they have symptoms suggesting stress, if they have symptoms of reflux, because population surveys have shown that up to 64% of patients who have reflux do notice that there's worsening of the symptoms when there's a stressful event. So trying to find out if you can manage the stress certainly will impact on the patient's function. The stomach itself, because it has acid in there, acid is not destroying the stomach, so there must be something which protects your stomach from all the acid that's in there, and that's the mucus barrier. And this mucous barrier is being produced by all the cells inside the gastric body, which get the signals from the same autonomic nervous system. So if you're affecting the autonomic nervous system, then you're going to affect the amount of mucus that's being produced, and that can lead to a loss of the protective layer. And then if you lose that, then acid will affect the stomach and cause gastritis or inflammation, and may cause an ulcer. So the ulcer would be loss of the surface lining of the stomach. Now, an ulcer is not going to happen because you're stressed. We used to say that. So stress ulcer used to be like the thing. So if you had a stressful person, they said, boy, you had an ulcer because you're stressed out. But then they discovered a bacteria called Helicobacter pylori, and they said, well, no, it's not stress, it's, the bacteria, because we found that 90 to 95% of patients, depending on where the ulcer is, have that bacteria. But we do know that the reverse is not really true as well. So we know that a lot of people who have the bacteria don't get an ulcer. So there are some other factors which may lead to patients having an ulcer. And so the whole stress thing is still in the background, but it's not the predominant reason why you may get an ulcer. But if you have a stressful event inside, that definitely will cause an ulcer. So the interoceptive stress is associated with an ulcer. So like patients who have major burns in a burns unit, or patients on ICU support for a long period of time, or have had major trauma, those patients are at risk for definitely ulcers because of internal stressful event. Inflammatory bowel disease is also associated with stress. So inflammatory bowel disease has two components. In patients who have inflammation of the colon, so the normal colon is the one that's sitting by itself, and on top and at the bottom you have ulcerative colitis and then Crohn's disease. And these are the two conditions which can be exacerbated by stress. And these patients will present with bloody diarrhea. So there are two conditions which we focus on: inflammatory ulcerative colitis and inflammatory Crohn's disease. In mouse models, you can show that if you subject the animals to a stressful environment, you can change the way that the intestine resists the normal bacteria which are inside. So if you can change the way that the intestines, for example, if your mucosal protection is diminished, all the little bacteria and so on in the intestine will now cause inflammation. That is the setup that they're postulating is responsible for inflammatory bowel disease in certain individuals. So the fact that the immune system is being affected predisposes patients to an abnormal inflammatory response. So there's nothing abnormal there. It's your normal bacteria that you normally have. But because your immune system now is out of sync because of the stress, you're responding to these normal bacteria abnormally. But it doesn't mean that you need to treat them with just stress relief. You need to still give them sulfasalazine, mesalamine, prednisone, or using one of the biologic agents, depending on whether they have mild, moderate, or severe. But we do know that stress will definitely influence the number of flares per year of inflammatory bowel disease. So, stress on the GI tract, which one came first? So, is it that the stress is going to cause the GI problems, or is that the GI problem is going to cause the person to get stressed? Well, there's no real way to separate it definitively, but you need to bear in mind that there is some interaction between the two. So I would thank you for your attention at this time.